to the Healthtech Pigeon podcast, where we break down the health tech news for you every single week. My name is Jessica, and this week I am delighted to be joined by, of course, producer Adama, keeping us all in line, and my colleague James, as well as a very special guest from ieso Digital Health, Clare Palmer. Welcome to you all. How are you doing?
Hi, thank you so much for having me. Doing great.
Awesome. James, you have come hot off another podcast. You just couldn't miss this one this week, could you?
I know, honestly. Yeah, I tried desperately to end the podcast, but it was just so interesting. And that will be out in a few weeks. Founder of Page AI, enormous AI company doing incredible stuff in the pathology space. But I'll let you guys listen to that when it comes out, because there's too much to talk about now.
Well, we'll give your voice a little rest for a minute. But the reason why James was so excited to join this podcast and has just flipped from one to another in a matter of seconds is that the pigeon really has got flapping about AI this week. And we have a full roster of AI stories right across the spectrum of the good, the bad, the ugly, and the better. So, as I said, we have a very special guest, Clare, joining us today to talk about our first story, which is a study. And we love a study. We especially love a study when it's done well, it has a great cohort, and it's talking about something that we are super interested in. So this study was a collaboration by ieso Digital Health and NIHR Bioresource. And can I just add, I had to ask Clare how to pronounce ieso, and she explained actually that the name comes from a Greek goddess. So tell us a little bit about the Greek goddess and what she does and why it is named for the company.
So ieso is the Greek goddess of healing and recuperation. And we are a mental health care company. So we've been delivering mental health care to patients within the NHS for over 10 years. So it's only too right that she is the name of our company and leading the way for us.
Awesome. That's a great name. Love it. And you can't really go wrong with a Greek goddess, can you? Awesome. Well, the study has shown that an AI-driven program has comparable effectiveness to human-delivered care whilst using up to 8 times less therapy hours. So this is a mental health platform that is using AI in addition to human support. And it's something that we often talk about is, where does AI sit in the context of the care continuum, and how does that work alongside what we believe to be a really important element of healthcare, which is that human touch. Clare, there are 1.2 million people in the UK on waiting lists for NHS mental health support. And I would love to hear a bit more about what this study found and what the implications are for the size of those waiting lists and the fact that we have a really huge workforce shortfall, but yet this significant need in providing care for mental health.
Yeah, I think it's worth starting with the problem that we're trying to solve. So right now, the rates of mental health conditions are rising across the globe. There are 301 million people who have generalized anxiety worldwide at the moment. And we do not have enough therapists to meet that rising demand. That has continually been rising since COVID as well. It's made it all worse. So what we're trying to do is use technology to really understand how we can scale access to care. But we want to scale access to high quality evidence-based care. And that's something that's really important to us. We've seen a huge proliferation in the number of apps for mental health support. I think there's over 20,000 currently available. But what we found, and it's constantly shown in the literature, is actually the effectiveness of those apps is not very good. They don't really work for people, and people don't tend to use them. They maybe start, they don't quite like it, they can't motivate themselves. And so what we've heard from our patients is really that one thing that's missing is the human touch and the human element. And so what we really believe in at ieso is that we can bring together the best of technology and the best of AI advances, but with clinical expertise and clinical care to create the right combination that is really going to help as many people as possible. So that's something that we're really trying to achieve. So we have conducted a study on our new digital program. And as I said, our digital program is all about combining the best of AI with the best of clinical care. So we've developed a structured 6-module program in which the user is taught skills based on cognitive and behavioral principles by a conversational agent. So this is where the AI comes in. And it's this conversational agent that can deliver and teach these skills in a personalized and interactive and engaging way. But what's really important is that wrapped around that program is a clinical and human support network. So every single person that came into the study had a clinical assessment by a human, by a clinician, which is really important to make sure that they were eligible for the study and they were suitable for the program. And then actually throughout the program, we said to our participants, if at any point you want to reach out and you want to have a 30-minute session to talk to a clinician, you can do that whenever you want. And actually what we found was that 94% of participants surveyed at the end of the study said that they really appreciated that and they loved that that was part of the program. But actually not many people used that service. And so we're still able to provide the support. We're still able to keep patients safe and also keep them motivated and engaged, and they feel like they're held in mind because they are, and we're monitoring their symptoms throughout. Yet actually in terms of like the health economic and the cost effectiveness of the program, we're not actually using, or the patients weren't necessarily using that clinical care as much as they could have. So I think it was a huge bonus, and several study participants afterwards said, I really appreciated the fact that I wasn't left alone with a bot, right? I think having that care and support really meant a lot to them. And I think that's why we've seen not only good engagement rates within the study, but also good effectiveness as well, because I think that does impact how motivated someone is, how much effort they put into their behavioral change that they're trying to see, and that will impact outcomes as well.
This is awesome. So I've been on so I'll set the scene here, right? So
I've primed Claire. I've primed.
Yeah, okay, fine. I've been on this quest.
Knows.
Yeah, fine. All right. So you know about the quest I've been on, this like existential quest to figure out like where on earth AI fits in with talking therapies and this, that, and the other. So yeah, on my travels amongst all the literature and trying to figure this out, my sort of initial conclusion was AI doesn't fit anywhere in this space. Since then, did more work and research on this and listened to a lot of people that spoke to me and found some people that thought otherwise. And actually my position literally just settled on it's horses for courses. And actually we need to figure out exactly where it fits in because it does have value. Bear in mind, I'm also a use case of it having value. Infamously, I used Wobot and it worked. So I know from a journaling plus perspective that it works there on someone like me that was, relatively mentally healthy, but trying to keep mentally healthy and all that sort of stuff. And it's like, well, if we start there, where can it go? I think the work that you've done on this is incredible because it's almost like the study that you've done on the model that you've got is one thing and is great. And you've proved that works and you've proved that it's wonderful. Actually, I think there's loads of work that you've done in the run up to this that actually deserves credit here to even know that was the model that was going to work. Because the thing that I've sort of felt along this whole journey of me trying to work this out is I know instinctively that it helped me in that one scenario. So what other scenarios is it? So I was like, well, journaling. Okay. It was like it was a two-way journal. And I was like, right, it definitely works as a two-way journal. And then it's like, what you said there, teaching skills. Wobot, in my example, taught me skills. It was like, you're catastrophizing. This is what catastrophization is. And these are some tools and techniques so that you can adapt it. I think what's wonderful, and it sounds remarkably simple here, actually, but just putting a human in the background that's sort of on call in a one-to-many model means that every individual feels that they've now got the human next door. everyone knows that they've got the human next door now. They know that they've got the human on tap. So actually, you might not necessarily need, or you don't need the human in the room to necessarily have 80, 90, even 100% of the effect of the human in the room. Just knowing and having that very authentic deal with the individuals going through it, that this is a bot and this is its purpose. It's here to teach you. And you can have a two-way conversation with it. But by the way, it is an AI. It's going to sound empathic. It's going to act empathic. And it's going to be nice to you, but it is still an AI. And you know that. And this is the deal we're having. But it's here to teach you. If you need anything more, there is someone next door that's going to come in and speak to you. It sounds remarkably simple. But actually, I actually think the value of the work that you've done was in the run up to realize that's the model. If I may, like, give you credit where you're perhaps not taking it, because I wonder how much went into deciding what that was.
And I'll take it. So our model really is, AI can deliver content, humans deliver care. That's what we're about. And actually, we are a mental health company first. So we've been delivering therapy within the NHS for over a decade. And we have an amazing team of clinicians who have first-hand direct experience delivering therapy for many, many years, who were the ones developing this product. They're the ones that really know what we need to do to maximize the engagement with therapy and maximize that behavioral change that we want to see in our patients. Alongside that as well, we do a lot of work with patients themselves. So we actually have some lived experience partners. So there is a lot of work around, I don't know if you know what I mean when I say a lived experience partner or an experts by experiences. It's something that has become I think more popular and rightly so. I think it's a great thing, right? Trying to center the patient voice in what we're building and what we're developing and how we're researching it, so that we always have them in mind. And that's something that we really take very seriously. So we have 4 lived experience partners who work with us as consultants at a kind of strategic level that really help shape the way in which we're approaching what we're doing. And I think that has been a huge part of our development process that got us to where we ended up.
So a little while ago, we actually talked about a study around use of AI and people's interactions with it and how truthful they were in their therapy session with an AI versus a therapist. And despite the fact that it was a small study, the overriding majority of people admitted lying in a therapy session. And one of the things that we talked about when we discussed that study itself was whether or not there was a role for AI in creating a safe space for people to be more honest and in those very difficult moments in a way that they might not, where there's a person on the other side. And I just wonder if that's something that's also been a factor in your decision making and how you've kind of built the solution that you have and how people have found that from your experience.
Yeah, I 100% agree with that. And we've heard that from user feedback and from patients themselves, that when they are talking to an AI, a conversational agent, there is an anonymity there and they feel more safe almost to reveal, lack of judgment. So they feel safer to reveal things that they maybe otherwise wouldn't. And I do think that's one of the benefits of these types of digital programs. What we're really trying to do is increase patient choice, right? This isn't for everyone, we know that, but actually for some people, this is a far better option than therapy because of the potential stigma or the fear or the anxiety with speaking to a person. And I think this is something that can also really help with health inequalities. There are particular marginalized groups, particular cultures where stigma around talking about mental health is very, very high. And actually being able to speak freely to a bot that is not going to judge them is really important. But also, you don't have to worry about that matching between the therapist and the patient. So that's something that's really important in therapy, right? Like having the right therapist for the right patient. For me personally, I'm a woman. When I'm speaking about my mental health problems, I want to speak to a female therapist, for example. And actually, you kind of remove that additional layer to therapy by creating this digital experience, which is judgment free.
Do you think that has influenced the willingness? You talked about how that can support different cultures and, marginalized communities and that kind of thing. But do you think that's influenced uptake in, for example, mental health for men, or like men accessing the solution that you've got? Because we know that women are more likely to access these kinds of treatments, not even just, technologies. Women are more amenable to therapy and more open to it and more likely to seek help, not just from a mental health perspective, but across the board in their health. And have you seen a difference there?
I think we've got a lot more work to do in that space. I think, as you say, women are far more likely to put themselves forward for therapy. And we see similar biases with research as well. So there are, particularly with marginalized groups, where there is a long history of distrust with scientific researchers. It's very difficult to get certain groups of people to want to engage in scientific research. So I think that is something that we've struggled with. And actually, I think we could do better in engaging those communities and highlighting what the benefits are. I don't think as a field, I'm going to say this across the digital mental health field, I don't think we're good enough at really making this a feature, that actually this is a place where you can come and speak with anonymity, and that can help you, particularly for these different groups. So it's not something we've seen specifically in this study, but I think it's something we need to work on. And I think it's a real plus point for helping helping decrease health inequalities within this space.
Do you have a view on what's causing the anxiety epidemic, or what seems like an anxiety epidemic? These rises that you talked about, 301 million people. I mean, these numbers are ludicrous, right? Is it, in part, go to first principles. Is it an increase in diagnosis, and actually this was the case anyway? Is it the fact that people are more willing to, access services and therefore take the diagnosis, and is that part of the increase? Is it literally the fact that everybody is more anxious? If so, do you have a view on what might be causing that? And I think an extension of that is, if there's a root cause, I wonder what that is and whether that needs addressing.
Oh, what a question. I don't know if I have a good answer. I think this
is more personal opinion, I think, than any company line. Like, this is more because you're in the field. Like, it's not even a tech question. Probably doesn't even belong on this podcast, to be honest, but I'm going to ask it anyway while I'm here.
It's a good challenge. And I think we don't know. And I think it's really difficult. Like, when you start talking about causal factors, right, it's really difficult to drill down onto what it is. And I think society is so complex. Biology is so complex. It's very difficult to target any specific cause. So I don't know if I have a good answer for it. Fair. It's a really tricky
culture
one.
Factors in, and language factors in, and like all these different things. Because I can remember as a kid, I wouldn't have known what anxiety was. I wouldn't have known anxiety as a term, but for better or worse, like it's in language now. And
we're increasing the way which we talk about mental health, which is a good thing, right?
Which is great for those that need to access it. Precisely. Yeah,
we're removing stigma, but it's a good question. Will we ever know whether we're talking about it more, therefore more people are reaching out, therefore prevalence rates are going up, or is it something else that's driving it?
Your study would suggest though that the overdiagnosis is not the case, because actually your study would suggest that for people with anything between severe and mild anxiety were getting meaningful treatment that worked and brought that anxiety down. Therefore, it must have existed. Do you know what I mean? Like, it's not overdiagnosed if your therapy works for it, right?
I'm not sure our study can say anything about overdiagnosis or diagnosis rates. I'm not sure I can comment on that.
No comment.
At the heart of it, we know that prevalence rates are increasing. We don't necessarily know why, but what we need to do is develop more solutions that increase and broaden patient choice and allow people to get the help they need when they need it, and make sure that help is high quality and is actually going to work for them. I think that's key. And our study has shown that.
So for you, what was the most interesting results that really kind of stood out to you?
So I think one thing we were able to show in this study, which is really exciting, is that not only do we see a large clinically meaningful reduction in anxiety symptoms within our sample, but it looks to be comparable to a matched patient sample from the NHS who received one-to-one clinician-delivered therapy. And that's really exciting because it means that we can start offering patients the choice to receive their care in the way that's best for them. We also found, which is really interesting, that the program really helped with day-to-day functioning. So it actually significantly reduced the amount in which people's anxiety was really impacting on their kind of day-to-day quality of life, and that the effect persisted at 1 month follow-up. So what that says to me is that our program is really enabling true, meaningful behavioural change that hopefully will be durable and will persist beyond the end of the program. And again, that's part of the framework that the program itself is about teaching skills that should then last beyond the end of the program. And actually, we've interviewed some participants who we spoke to recently. And actually, it's been 2-3 months on from the study, and they're still using the skills that they learn as part of the program, and they're still feeling better. And it was really, really great to hear that.
The as good as one-to-one bit is just absolutely crucial, isn't it? Like, that's the bit when you take a systems view, that's the real bit where you're just like, wow, okay, like now we can do one-to-one therapy with unit economics that works, or unit economics that works a bit better. And I think that's the thing when you're procuring stuff like this and trying to, find health economic models and budgets and all the rest of it and justify the use of it. That's clearly the part that really does the heavy lifting in those conversations, I imagine.
Yeah, and it's important to note that it didn't work for everyone, and it won't work for everyone.
No, absolutely, and
I think that's
great to recognise.
Yeah, which is absolutely fine, but it's I've said this a couple of times, but it's broadening that patient choice, and it's offering a choice that is of high quality. And I think that's what's really important. I think when people are in need, they'll often kind of go to lots of different sources to try and find some support. And actually, most of the apps, most of the things out there are not evidence-based. They don't have science behind them, and then they're not necessarily going to help. So being able to provide a digital solution where people can use it when they want it, when it's convenient for them, and have that kind of anonymity with when they're really sharing some of their most difficult symptoms and parts of their life, I think that's really, really important.
This is probably quite useful for talking about health tech more broadly, but have you noticed correlations across any particular cohorts of people or demographics in those that for whom it works and for whom it doesn't, or definitely works or works really well, or definitely doesn't and works really bad? Like, have you noticed any similarities in groups there that we can use?
Yeah, so an interesting one actually is that older participants in the study tended to engage with the program more and had larger reductions in anxiety.
Interesting.
And I think that goes against a lot of what people assume with digital solutions, that if there's an app involved, it's going to be all of the kind of young people that are really kind of tech savvy that will kind of want this type of therapy and do well with it. But actually what we find is that it's the majority of people in the study were actually middle-class women who had families, who had very, very busy lives. You have a job, you have kids, maybe you've got a dog, and it's a very difficult, busy schedule to try and then fit in a one-to-one appointment with a therapy between the hours of 9 and 5, right? So I think actually that cohort really benefited from it. And actually one of our participants said recently, one thing she loved about the program is that it was a form of self-care for her. And what she would do is it would be kind of late at night, kids have gone to bed, she would sit on the sofa with a blanket and her cats, and she would work through the program. And so enabling people to create the space that they need when they need it in order to get better is really, really important.
The program nature of it, I imagine, as well, is there's something within that you're seeing progress throughout it. You're getting to milestones. You can see graphically, I imagine, or on there, like the progress that you've made and how much you've got left, and it's quite motivating, I think, to run it as a program in inverted commas, like acknowledging that there's within this program there are a finite amount of things that you will learn, and therefore, rather than, I guess, broadly sort of therapy, which can feel quite open-ended and quite a daunting thing to put in your life.
Yes, I actually love that you brought that up, because this is something our clinical team, our clinicians talk about a lot, actually. They think of this as a course of an intervention, right? It's an episode of care, and it's where each module and each session builds on what you learned in the last. And so any other skills-based course, you would want to progress through certain modules. And I don't think many other digital programs think like that.
Agreed.
And often it's... Often when you go in, either there's free-form conversation that can sort of go anywhere, or there's an option, there's a menu of several different activities you can pick. But, me as a patient, I'm not the expert in which activity I should pick
Agreed.
at any point in time, right? Actually, I want a clinician to decide that for me. So what we've done is actually we've curated a program, or our clinical team have curated a program that will build on those skills and really teach people what they need to do to get to their end goal. And I think that's something that is quite unique to our program that patients have found really beneficial.
And just a final question for me, just on the more, I guess, that the healthcare nature of it. Where's the line between, I guess, mild anxiety and just wanting to prop up your normal, in inverted commas, mental health? I imagine that line may be different for different people. Like, for whom is your course, for want of a better word, in this scenario for? Because the reason I ask is because of what you said actually earlier on, that those people that learnt those skills in the moment have then gone on to keep that as a skill, to keep that mental health propped up in future when certain things happen, to help with resilience or, not catastrophize, or all those different skills are then used at periods of relative normal but low end of normal to keep in normal range. So it's interesting. Do you guys draw the line at diagnosed anxiety, or do you offer for everyone?
Yeah, so we see ourselves as a healthcare provider. So we do, particularly in our UK therapy business, we essentially treat people who come in the front door who have their anxiety is severe enough that they've gone to their GP, essentially.
Understood. So it's
and
NHS
they need
services.
help. So it's at a slightly different level to available for anyone. And I think it's actually, so what you find with cognitive behavioral therapy, it's hard work. Like, it really is hard work, and it requires a commitment. And actually, in the study, people use the app for up to 9 weeks, and there's multiple sessions a week. Like, it's not an easy thing to do, to really change your behaviors to reduce symptoms of anxiety. So I would say that I think if you're not quite anxious enough, there's probably not enough payoff in it. I don't know if that's the right way to put it, but it's a high effort to get it back. So I think that's the space where we kind of spend a lot of our time.
Yeah, and that's obviously, pound for pound as well. That's the place where you'll make more impact, and therefore it makes more sense. Yeah, totally. Yeah, understood.
Okay, so switching gears from one taboo to another, but sticking with a theme, still AI, of course. We're talking about STI selfies. Now, it's not something it's a new term to me, not something I thought I'd be talking about on a podcast. Mum, Dad, hope you're not listening. Maybe you should be, who knows? But this story comes to us from some researchers in Australia who have developed a platform that allows patients to take photos of anomalous lesions and submit them, and an AI can then review them to diagnose whether or not they might have an STI. And I guess when you talk about it like that, it sounds kind of sensible, because you have something similar, for example, or, we have lots of similar platforms for skin cancer, where you can take photos of moles and lesions and that kind of thing of your skin and submit them, and AI can run a first pass or, do a first digital triage before it then gets sent on to a clinician. So from that perspective, it totally makes sense. I think just because of the topic, it just feels a little bit uncomfortable. And I have to also call out Pigeon's handiwork this week. I'm not going to spoil it, but if you haven't read the commentary on this story, Pigeon's really outdone themselves. So make sure you go and read that if you just want a bit of a giggle, because sometimes you have to. But James, what's your take on this one? Good, bad, ugly, indifferent?
Yeah, it's good and ugly. I think. It just makes sense, right? Like it just makes sense. You move care closer into the community. You look at, I guess, sexual health services broadly. Like there's a lot of at-home testing now. Things are moving closer that way. It sort of just makes sense. It's the direction of travel. The podcast I've just recorded, on the other podcast with the founder of Page, it's computational, in that case pathology, it's computational imagery still, but applied to a different area. Like instead of cells, we do this for melanoma, we do skin analytics, skin vision, like we do this on the skin already with dermatoscope images and smartphone images, even for some of them. So for me, this is just the direction of travel. It just makes sense. It makes nice headlines. It allows us to be talking about it. It will create quite a lot of clickbait. I think there's obvious things around it, though, that obviously the requirement for very clear security around where those images are kept and what's done with them and all that sort of stuff, of course, will come into this. But I think as well, you're dealing with, they talk at the end about same technology being used in things like cervical and anal cancers as well. So I think you're dealing with a section of the population that are incredibly motivated to get a solution to a problem, and for whom the issues that they may have around cybersecurity and all the rest of it might actually be superseded by, I just want this problem solved as soon as possible, because they've looked at the sexual health services available to them, and it's either an incredibly expensive test to be delivered home, or it's actually days until they can get an appointment for something that's relatively active. So as I say, I think it is the direction of travel. It is quite clear. I would be surprised if there aren't companies that already are the kind of online diagnostics, send in an image and we'll just post a treatment to you. I'd be surprised if they're not looking into this anyway, and probably quite a lot of them.
Yeah, and I guess just to pick on something that we were talking about in the context of mental health as well, and obviously the work that Clare and the team at ieso are doing, is that one of the things the article points out is that there is a barrier to accessing care because it is such a taboo, and where even where people are, there may be a delay to seeing someone in person, but there's a huge amount of stigma attached to things like STIs, and it's embarrassing. And the thought of having to sit there with your legs open, someone looking in your most intimate areas, is really uncomfortable. So if you can skip that step and get straight to the diagnosis and the treatment without having to put yourself in such an uncomfortable position, that is also a really important way to kind of pulling down those barriers to people, more people getting the care that they need, so that they're not existing with whether it's an STI or any other condition, for any longer than they need to, out of embarrassment or stigma and discomfort. And I think, these are rules of engagement that can be applied in so many areas of healthcare, that understanding actually that sometimes the barrier to getting the care is actually the discomfort in taking that step. And it's a lot easier if you can just, of course, no, it's probably not enjoyable to take a picture like that, but take a picture and send that off. And then out of sight, out of mind, you don't need to think about it. Instead of spending, a week worrying about the appointment that you've got and feeling awkward and embarrassed and
potentially infecting others. Yeah, it's true. So I think it's great from that perspective. Claire, what do you think?
The only thing that concerns me with these, I completely agree with everything you said, apart from I worry that people will become over-reliant on these technologies.
Yeah, that's
and
true.
Where the accuracy isn't 100%, what is the kind of risk or the impact of those people in which the kind of diagnosis is not correct? So my hope would be that tools like this reduce stigma and get people more comfortable with checking and assessing themselves, but hopefully still encourage people to go into those clinics and don't become a replacement for them.
What if it increases risk-taking behaviour if it's just actually too easy to sort out? One of the things that keeps GP waiting lists low is the fact it takes you 8 days to get an appointment. And by the time you've got the appointment, it's resolved anyway. So like, what if it's just like, take a picture and then it gets delivered in an hour, your penicillin, all of a sudden you then got like an absolute raging syphilis outbreak across the country.
Apparently syphilis and gonorrhea is on the up in older age
Super
groups.
gonorrhea.
Yeah.
Indeed.
Yeah. Claire, it's as if you knew what story was coming next, because I think that's actually a great segue into our final story of the day, which comes to us from Medical Express and asks the question, are AI chatbots suitable for hospitals? And it's examining the diagnostic capabilities of LLMs. One important caveat to say is that ChatGPT and Google's large language models were not tested in this study because it was one of the conditions of the release of the health data from the healthcare organizations to protect the privacy of those patients. But it's obviously exploring this idea of using AI for diagnosis and understanding its reliance. And I think one thing that isn't news to us is the fact that humans are also fallible and humans don't get it right 100% of the time either. And that is acknowledged in this article. And I think it kind of links to what you were saying about, where technology isn't perfect, but also neither are humans. And I think it's kind of finding that balance about like, not the lesser of two evils, but making sure that there isn't that over-reliance, but not holding technology accountable to standards that maybe humans aren't accountable to either. And whilst obviously patient safety always has to be number one, we want to optimize patient care, so that's really critical. But this study was super interesting because, as I said, it analyzed, I think it was 5 different large language models. And again, for those of you who have read Pigeon this week, you'll see that we've borrowed a lovely little graph that shows some of the results. And I'm really embarrassed to say that as I was looking at the graph, I read the story and I could see that obviously these large language models are being compared against doctors, so real life clinicians, and their diagnostic capabilities. And as I was looking at the graph, I was looking at the different LLMs and I saw the names of the LLMs and I was like, oh, doctors, that's an interesting name for an LLM. I haven't heard of that one, but it seems like quite a good name. And then I realized that was real people. So I'm blaming that on baby brain, but just putting it out there. I misread that diagram, but it is very useful if you want, you're a visual learner and diagrams are useful to you for digesting information. But yeah, basically, one of the really interesting things that leapt out at me was that compared with doctors, the doctors got 89% of their diagnoses correct, but the best LLM only achieved 70, I say only, but achieved 73%, which obviously is, if I do my maths, what did I say, 89? So 16% difference compared to a doctor, but that is the best LLM. And so there was variation amongst them. But the most interesting thing was each model performed better in some disease areas than others. And the reason that sticks out to me is I think it's a really stark example of data bias on which, so the data sets on which AI is trained, and where we're seeing this variation leaning towards certain diseases and conditions than others, it does make you question, but also realize that how important the data that these models are trained on is in determining the result that it gives you. And you extrapolate that at scale, and the results can be quite disconcerting. And I know it's something we talk about quite a lot, but it's the first time I've seen data that's not directly talked about data bias necessarily in AI, but I thought it was a really good representation of that.
What the big issue that I always have with these types of models is tech versus doctors. And so this is the problem I have with these sorts of papers. It's like tech versus doctors, LLM versus doctors, AI versus doctors, diagnosis is this versus doctors, versus doctors, versus doctors. You can only say versus doctors for so long before doctors turn around and be like, why is everyone attacking us? Like, we're doing our best around here. Like, can you stop like comparing like wild technologies against us? Like, we're just out here doing literally everything from a human capacity and from a basically tech capacity and from an admin capacity and from a learning capacity and from a research capacity and from a management capacity and from a finance capacity. Like, we're doing everything here. Like, stop just like putting things against us. Like, my God, we're just trying to do our best. Like, so that's the first issue that I have with all these types of things. So I don't think it creates a very sensible discourse, because a much more sensible discourse is like tech plus doctor or doctor on their own. Like, I just feel like that's just such a much more sensible way of doing things than this like obsession with can the tech stand up on its own. It's never going to be put on its own. You're never going to run an A&E department based on an LLM overseeing it, telling in an agent model, you know, the machine that's plugged in with the bloods to do something, or the machine, like that's never going to happen. So I don't understand why we keep doing this. And I sort of get it for benchmarking perspectives and all the rest of it, but like the way it's then reported, I just think is so counterintuitive for what you're trying to do, which is to unite clinicians with technology and actually to keep clinicians at the top of that pile and use the technology as a tool. Like, frame it like that. Like, so that's my first reaction to this. Now, the other reaction I have to this is almost contrary to that in a way, which is like, yeah, the team found that none of the large language models consistently requested all the necessary examinations. Like, that's the first thing they say. I'm like, well, okay, like, just tell it where to pull the information from. Like, use local hospital guidance. That's a case of just telling it to look in the right place. And I'm sure it would. Like, it doesn't feel to me like that's a big deal. By the way, this is me not being an LLM expert and I don't build them, but like, from a pretty heavy user of this stuff and talking to people that build them and working with some companies that use hospital guidelines to come up with various things, you know, the MedWises, the OLASes, you know, all these different things. Like, that doesn't seem like an insurmountable issue. Yeah, okay. Correct in 89% for doctors' large language models, and just 73. A technology that is a pure technology that's basically a human in a box, almost, just 70. Not just 70, it's remarkably accurate that it's 73. It's just not accurate that we're going to use it on its own. So it's remarkable that it's 73. It's like the thing when ChatGPT came out and everyone was like, oh, it's great, but you know, actually ChatGPT is like hilariously bad because like it can't even count to 10. Like, if you tell it to name 10 things, it names 11. And like, what are you talking about? Why are you highlighting that when you can literally get this thing to write like the works of Shakespeare in a prompt? Like, and yet it can write the works of Shakespeare in a poem style sounding like Jack Sparrow. Yet you're saying like it can't count to 11. Like here, like the best large language model achieved just 73% of the diagnoses. Like, that's incredible, given that like the technology is not going to stop here. Like, this is the very first iterations of this stuff. It's clearly going places. And so, like, you know, another problem that disqualifies the programs for everyday use is a lack of robustness. That assumes that anybody was about to qualify the program for everyday use on its own in an A&E department. I think it's incredible that these things are achieving the accuracy that they are, when you then put it into the model of what if it's human plus the large language model. So that's the issue that I have with this broadly. That's where I think it should go. Like that, I think we should just be talking about this differently.
I couldn't agree more with that one. I think there's this separation between science to understand how a technology is working and the capabilities of a new technology, and as you say, benchmarking it to understand how far have we got and how well is this are we on that path, versus right, we actually want to do research which has an application which is going to be translating directly into a healthcare system and have impact tomorrow. How do we attack that problem? And I think they're two very separate and distinct problems that need to be spoken about in a different way. And I think too often we try and combine them together, and that's where the story can get confused.
I do think it's confusing, because I think it's incredibly worth us talking about where are we going with this? What is the goal that we want? And now let's unite as a community to get there, which involves academia and research. It involves the way that we put these studies together. And it also involves the way that we communicate them as well, as the press, as journalists, as all these things, because we're all united in wanting to go somewhere. My issue with journalism like this is that it gets people's backs up. It will prevent an openness and a willingness to engage in conversation. And you're at risk of alienating the very people that are on the ground floor doing all the work right now, by the way, being told that they're being compared to this technology that's been out for 5 minutes, which, by the way, could be incredibly helpful in the future. And so I just think it's a very strange way that we've sort of nobody's really decided. I think that's sort of it's been a lot of my point recently about, if we don't define where we're going and what we want, we're at risk of just wasting loads of time doing things that aren't productive. I think this is an example of that. It is my opinion, and I'm willing to have that change with new information. But like, I do just worry for the state of play if I read another doctor versus tech like headline. Like, it does just get on my nerves, like, from people that have never been on the ground floor, like daring to speak like that. Like it does just upset me.
Yeah, I think you make a really good point about alienating the clinical community. The only way in which these technologies are going to advance even further than where they've got to and actually be able to make real impact is by engaging doctors, clinicians, nurses, the people on the ground that will be using them, and the people with the expertise to really build them in the way that's going to help. So we need to do everything we can not to alienate those communities, and actually to bring them into the fold, educate them in how these technologies work, and work in collaboration to really move the field forward to real impact.
100%. And that's the macro. And in the micro, in this study, they could have just had group number 3, which was both together. Give the clinicians the LLM, and then see what the diagnosis accuracy was, and then see what the accuracy of the investigations was, because you're actually going to get that accuracy of the human, which was 83 or whatever. And then of that 73, I'm sure some of that 73% would have filled in, you know, if it was 89%, well, the other 11%, and actually gone some way to actually getting closer to 100. So that's the bit. Or
just communicate. Communicate the results differently. I think that's more the point. I don't necessarily think that there's anything wrong with doing the comparison. I think it's important to have that gold standard benchmark, and we need to know how to improve technologies and what our target is and where we want to get them towards. But I think it's the way it's communicated. As you say, an LLM will never be left alone. No, it's not going to happen tomorrow that an LLM on its own is going to start diagnosing within a hospital. It's just not going to happen. So it shouldn't be set up as if that was the goal.
Yes. So I will concede. It's the communication element. I'll concede that. Fine. So Jessica's run out of time. She's had to go. So I will close out today by saying, Claire, it's been an absolute pleasure. Thank you so much. Thank you for all the work you're doing with ieso Health. It sounds like you were at the conclusion of, AI plus human equals great care quite a while ago, in fact. And I think a lot of that learning, let's hope it proliferates across the healthcare system the more LLMs come in. And yeah, let's hope there's no doctor versus ieso Health, because ieso Health is both. It's going to win. So, right, been a pleasure. Thank you so much for joining us.
Thank you so much. It's been a great chat. I've really enjoyed it.
Awesome. And if anyone wants to get the links to any of the stories you talked about today, you can grab those in the newsletter, which you can get at healthtechpigeon.com, and you can subscribe to that newsletter. It comes in your inbox every Sunday. Claire, thank you. Adam, thank you for producing. And Jessica, she's gone, but thank you. This has been Health Tech Pigeon. See you all next week.